This video lecture is going to discuss pain. Pain is our perception of trauma within the tissues of the body. And so it's valuable for you and me as clinicians to be able to understand what's causing pain and to be able to identify the different types of pain that our patient is describing to us, because that can be very valuable in helping us to learn a lot about what's going on in their body, what has happened, what is still happening. And so pain is not something we usually discuss in A&P1 and A&P2. This is a good time to bring this up and to be able to describe some of the elements involved. Now, we will discuss the types of pain and show how there's different receptors in the body that can each provide different types of information. The physiology of pain, which describes a couple of concepts like referred pain or fast versus slow, and then assessment of pain, which is something very valuable for you as a clinician to understand. Now, you have different receptors in your structures of the body that can give you different pain information. So that's why when the patient tells you it hurts, you'll ask them questions, describe the type of pain, describe this and that. Cutaneous pain is superficial. That's something in the skin. And so if it's been a cut or a bruise or chemical exposure or something like that, it gives you an idea of what structures are affected. Somatic pain is very precise. It's usually something musculoskeletal. And so, someone who, got hit really hard with a doorknob and has a bruise right there, they say it hurts right here. Or if they wind up falling, hitting their elbow hard enough and it's really sore right there, and they can usually tell exactly where it is, that's usually a musculoskeletal issue. Visceral pain usually is something that's more in the torso of the body and it's more diffuse. My gut hurts, doc. And it's like, well, okay, you got to ask a lot more questions to figure out, what exactly is happening in the gut to be able to help you figure out what type of structures are being affected. Neuropathic pain is abnormal perception due to some type of sensory receptor misfiring. We've talked about Navajo neuropathy and diabetic neuropathy before, and that's the idea that the neurons are sending incorrect information to your parietal lobe in the brain, saying there's something going on, but I'm not quite sure what. Or it may give you the wrong information, and my foot feels really cold. But when I feel it with my hand, it doesn't feel cold, but I do notice that, there's been a lot of scraping on the bottom. And so my brain's trying to interpret bad information. Referred pain is perceived from a different location. That means that you've got a damage in one area and your body thinks it's coming from another. I'll show you an example of that in a second. When we take a look at the sensory receptors out in the body, sending information up through the spinal cord to the parietal lobe in the brain, there's two major categories of pain pathways traveling up to the brain. There's tonic pain pathways and phasic pain pathways. Tonic pain pathways will send diffuse chronic information. That's going to be things like a sunburn, or if you had dental work, and so now it's just kind of throbbing for a while, or if you wind up falling yesterday and you got a bruise on the shoulder and it's just sore for an hour or so. That would be examples of tonic pain. Phasic pain is very localized and acute. It immediately tells you exactly where it happened and when it happened. And so when you get, a paper cut, that would be an example of phasic pain. The body immediately knows when and where that happened. When you get a bug bite, when you get stung by a bee, you immediately know when and where. In your spinal cord, you have tonic pathways traveling up to the brain, you have phasic pathways running up to the pain. When the phasic pathways send the signal up, they send out hormones called enkephalins that temporarily mute the tonic pain pathways. And so the example you see, if the woman here, let's say that she has an upset stomach because she's low on food, she's a little hypoglycemic, her gut is belly aching at her, she's had a long day, a little bit of a caffeine headache, all of that would be tonic pain. She's making dinner, and as she reaches for the lid, it suddenly pops off and she gets hot water all over her hand. Phasic pain is going to scream up through the brainstem. At that moment, the brain doesn't care as much about the headache or about the bellyache. It wants to know what the hell just happened to the hand. And so at that moment, suddenly everything else is ignored in priority of the survivable, what is, oh my God, just happened. Now, this is why you'll notice that anytime you hurt yourself, say you smash your fingers in a door, first thing you do is you rub it or you lick it, something where you rub the finger that just got caught in the door. That's because rubbing is stimulating those tonic receptors. I'm sorry, those phasic receptors. And so if I have throbbing and I sit there and rub it, my brain does not perceive the throbbing, but it perceives just the tonic if I stop from good. This is why we rub insect bites, which is stupid because that scratching is only going to cause more damage when you're done. Now the previous tonic information will be added by new tonic that you caused. That's why things like insect bites or rashes, it's better to gently tap them because the tapping will still stimulate the phasic receptors and your brain won't pay attention to the tonic. When you stop, the tonic will come back, but it's not worse by you digging and scratching. So that's why we're trying, pediatricians are trying to teach little kids with things like measles or chicken pox, don't scratch it, tap it. I watched one time a pediatrician teach these little, games and little, sing-along songs to kids, but it was fascinating to see the logic behind that. One of those cool things. I mentioned the referred pain. Referred pain happens because pathways of pain fibers tend to group into certain spinal roots going into the spinal cord. So, for example, you see the chart here that shows you this area for the heart and this area for the stomach, they're really close. And so, if your patient has acid reflux. They eat a lot of really spicy food, and a little bit of acid reflux goes up just above the sphincter into the esophagus, causes a little bit of indigestion. We call that heartburn because that pain pathway goes into the same pathway of the pain fibers around the heart. They go up to the brain, and the brain looks at its map and crap. I'm seeing pain from the heart. I'm having a heart attack. And so your brain is freaking out, thinking it's having a heart attack, but it's indigestion. On the one hand, this can freak out the patient, can freak you out unless you pay attention. Start asking other questions and start realizing, okay, no, you're telling me stuff that, we'll do an EKG, heart is fine, you probably have some indigestion. On the other hand, this can be useful, referred pain can be useful because let's say that your patient comes in and says, past day or so, I just can't can't catch my breath. And my armpit has just been really sore and it's been kind of numb around this part of the chest. Okay, in that case, now we're having heart pain being misinterpreted as somatosensory chest pain. And so peripheral pain can be distracting or it can be valuable, depending on how much you pay attention, a good history and physical. I'm not going to test you on this chart. So don't worry about memorizing this chart of locations, but be able to describe what referred pain means and be able to give a good example. And explain the example. Don't just simply say heartburn is an example. You got to explain the whole story. All right. Well, pain is so subjective that we've got to learn a lot from our patient. And there's different assessments that we use. The most common is the OPQRST regimen. And so this is very commonly used in a lot of clinical locations to help us learn a lot about the type of pain and the details that go with it. And so O is onset. You ask the patient, when did this start? Provocation. What provoked the pain? Were you doing something that caused the pain to occur? Quality of pain. Is it, a diffuse pain or a sharp pain? Is it a stabbing pain, a crushing pain? Region of pain. Where is it? Is it localized in one area? Is it radiating all over a sporting area? Is it a specific spot? Severity pain on a scale of 1 to 10. How severe is it? Time. How long has this been going? Has this happened in the past? And so understand what each one of these letters stands for and what that means. This is important for you as a clinician to help you be able to interpret the subjective nature of what your patient tells you and turn it into objective facts that can help you with proper diagnosis and proper treatment. For severity, the tricky part about that is, again, you're saying, like, say on a scale of 1 to 10, or a simple descriptive scale. There's lots of different scales that we can use. Um, you can even do emoji scales if you've got someone who English is not their first language, or a little kid, or someone who has some type of speech disability. There are different ways. You can even throw big charts like this and point to the one that you feel like. And so you can get a lot of information from little scales like this. All right. That gives us some basic terminology as far as the types of pain, the difference between phasic and tonic pain, referred pain, and our OPQRST assessment. Review that information. Let me know if you have any questions. Good luck.